Hello, everyone. This is Dr. Jennifer Galvin, and on behalf of the Online Media Committee, we welcome you to an excellent webinar with our panelists that are experts in pediatric ophthalmology and neuro-ophthalmology, talking about CVI as well as a parental perspective. I'm going to ask for everyone to hold their questions till at the end, and then you can also put them in the chat. And so I'm going to take this opportunity now to introduce all of our speakers. We have 6 of them. So welcome. We're just going to start off with Dr. Grant Liu. His talk is entitled Ideologies of CVI. And Dr. Liu is the Raymond Perlman Endowed Chair in Pediatric Neuro-Ophthalmology. And at the University of Pennsylvania, he is professor in the Department of Neurology and Department of Ophthalmology. Next will be Dr. Richard Legg, and his talk is entitled Clarifying the C in Pediatric CVI, and he is an assistant professor in the Department of Ophthalmology at University of Nebraska. Next will be Dr. Terry Schwartz. Her talk is entitled Validated Screening Tools to Aid Identification of Children with CVI. And Dr. Schwartz is a professor of ophthalmology at the University of Cincinnati. Next will be the talk by Dr. Linda Lawrence entitled Challenges and Support for Babies and Small Children with CVI and Their Families. And Dr. Lawrence is an assistant clinical professor in the Department of Ophthalmology at the University of Kansas. Next will be Dr. Sharon Lehman, and her talk is entitled Challenges and Opportunities for Older Children and Younger Adults with CVI. And Dr. Lehman is clinical professor in the Department of Ophthalmology and Department of Pediatrics at Thomas Jefferson University, as well as Division Chief in Pediatric Ophthalmology at Nemours Alfred DuPont Hospital in Delaware. And last but certainly not least is a parental perspective with a talk entitled Learning to See, a Parent Perspective on CVI, Ms. Gunjan Rostgoni Wilson, who's also a nurse practitioner. Again, thank you so much for joining us today. It's Tuesday, September 29th, and hearing these fantastic talks from our 6 panelists. Without ado,
Okay, thanks to AAPOS and Dr. Galvin for asking me to speak, and good evening, everybody. My task today is to go over briefly etiologies of CVI. This is my disclosure. I'm purposely not going to say what C stands for in CVI. V stands for visual, I for impairment. Skip will talk about what the C stands for, but we'll just call it CVI for now. And a definition by Skrzynski and Good in 2004, I think works quite well for this. CVI is a condition in which children have reduced visual acuity as a result of damage to the posterior visual pathways. In most cases, the eyes of such children are structurally normal, yet they have diminished visual capacity. So I tell patients that this is a brain-related vision problem and not an eye-related vision problem. So in most instances, glasses will not help. I want to add my own comment to the definition, and that the brain problem usually is bilateral, and we'll get to that in just a second. So I want to go over a little bit of neuroanatomy. We don't have to really go over the anatomy here of the eye, but again, I just put this up to emphasize that we're not really talking about retinal problems and optic nerve problems. In this diagram here, again, visual information, just to review quickly, of course, starts in the eye, goes back through the optic nerves and chiasm, through the optic radiations to the lateral geniculate. So any lesion of the optic nerves, chiasm, or optic radiate, of the optic tracts, would not really qualify for CVI. So what we're talking about is the posterior visual pathways, those structures after the geniculate. So here you have your optic radiations and then the occipital lobe. So these would be lesions typically of the temporal lobes, the parietal lobes, and the occipital lobes posteriorly. I put this here to emphasize, again, the bilaterality of the problem, because if you look at lesion D, which is a unilateral lesion of the Meyer's loop, that part of the optic radiations in the temporal lobe, you're just going to get a quadrant defect on one side. If you have a lesion here, unilateral lesion of the occipital lobe, you're just going to get a hemianopia on the other side and have intact vision on the other side. And typically, unilateral lesions of the posterior visual pathways do not affect visual acuity. However, as in this instance here of an individual with unfortunate bilateral occipital lobe strokes here on the right and the left, involving the bilateral posterior cerebral artery distributions after cardiac surgery, you're going to have bilateral vision loss because you have a hemianopia on the left from the right side of the lesion and a hemianopia on the right from the left side of the lesion. And of course, this would lead to blindness with bilateral occipital lobe stroke due to bilateral occipital lobe stroke. So I want to emphasize the bilaterality of most of the processes that we're going to be talking about in CVI. Now, I wanted to talk about higher cortical visual processing because many of these destructive lesions affecting the occipital, parietal, and temporal lobes will also affect visual processing. What do I mean by that? What happens with the visual information once it reaches the occipital lobe or area V1? Well, it turns out that a lot of visual processing, believe it or not, actually starts early on in the retina and in the so-called dorsal pathway or the dorsal stream. Visual information is already separated starting with the M retinal ganglion cells, which project to the magnocellular layers of the lateral geniculate nucleus, that's layers 1 and 2, then to V1 in the striate cortex occipital lobe, and then visual information is forwarded to V5, the motion sensitive area part of the brain, then to the parietal lobe. Again, this is the dorsal stream, and it turns out this is going to be the where pathway. The what pathway, or the ventral pathway, starts in the with the P retinal ganglion cells projecting to the parvocellular layers of the lateral geniculate nucleus. That's layers 3 through 6, then to V1, then to V4 complex, which you'll know is the color processing area, then to the inferior temporal lobe, which is the object recognition area. So the ventral pathway or ventral stream is the what pathway. This is a cartoon of monkey brain showing essentially the same thing, that when visual information reaches area V1, the brain processes what information by passing through V2, then the color area V4, and this is again called the ventral or object recognition pathway, onto the temporal lobe where there are other areas for recognition. The where pathway or dorsal spatial vision pathway through V2, then the area MT, which is the monkey equivalent of human V5, the motion sensitive area, then to the parietal lobe. And then, so this is how the brain processes visual information. And Skip will talk a little bit more about that in his talk. This is just the a cartoon of human brain, again, showing essentially the same thing. You have area V1, again, projecting dorsally. This is the, again, the where pathway, and ventrally, and that's the what pathway. Okay, so let's go over some of the major etiologies of CVI. And I constructed this list using a chapter from Christine Roman-Lancey's very nice book, again, that Skip will show you. And you can break them up essentially into neonatal disorders. And most of the conditions that we are going to see in the office, in the hospital, are going to be related to neonatal disorders. So we'll show you a case of hypoxic ischemic encephalopathy, or HIE. We'll show a case of intraventricular hemorrhage, or IVH. We'll show a case of periventricular leukomalacia, PVL. We'll show you a case of genetic and metabolic disorders, and we'll just touch later on structural abnormalities and infection, and we'll show a case of acquired disorders. But most of the cases that we're going to see, particularly in young infants, are going to be related to neonatal disorders. So I think this is probably the most common etiology that we're going to see, and this is hypoxic ischemic encephalopathy. Hypoxic, of course, meaning decreased oxygen; ischemic, of course, meaning infarcts to the brain. Encephalopathy is just a general term for brain dysfunction. So this is brain dysfunction due to lack of oxygen and infarcts. This is an unfortunate infant that I saw with the MRI on the left that presented with severely decreased vision, microcephaly, a small brain, small head, spasticity, developmental delay, and this was all due to perinatal asphyxia with lack of oxygen during birth. And this T1 weighted MRI shows a severe encephalomalacia, and what that means, encephalomalacia means brain shrinkage, and you can see that all this black area is spinal fluid, and essentially there is just no brain tissue posteriorly. And these areas here are called cysts. So this is called cystic encephalomalacia in these areas here. And you would completely expect someone like this to have poor visual dysfunction because of the bilateral occipital lobe lesions, poor motor function because of the frontal lobe abnormalities, and spasticity because of the upper motor neuron lesions. Next common cause would be intraventricular hemorrhage, or IVH. This was the MRI of a patient that I saw, a 7-month-old infant born prematurely at 32 weeks. I didn't find the child to fix or follow, blink to threat, or grimace to light. There was severe motor delay. And the T1 weighted MRI here shows these bright areas, and areas that are bright on T1 weighted MRIs typically represent blood. And this is a grade 3 hemorrhage on this side, grade 4 hemorrhage on this side, and the grades refer to how much blood is in and around the ventricle. So if it's contained or just next to the ventricle, they tend to be called grade 1 through 3. And if there's blood in the ventricle extending way outside, that's called grade 4. And you'll notice these dark areas here around the ventricle. These are areas of ischemia, and the left side in particular has become very ischemic. And the child, because of the blood blocking the ventricles, developed hydrocephalus, required a shunt, and really is severely developmentally delayed and has severe vision loss. The thought of the etiology of the IVH is due to fragile blood vessels in a premature infant. Another etiology that we'll commonly see that causes CVI is periventricular leukomalacia. This is the MRI of an infant born prematurely, again, and presented with decreased vision. And you can easily see these abnormalities on the T2 weighted MRI. And what you see here is these high signal areas and thinning of the posterior periventricular white matter, where the arrows are pointing right here. There should be much thicker optic radiations in this area, and they're very thin. And as a result, the adjacent posterior horns of the lateral ventricles are dilated. PVL is thought to be due to a vascular process in premature and low birth weight infants. Occasionally we'll see genetic and metabolic disorders cause CVI. This is an MRI of a child with X-linked adrenal leukodystrophy, and what leukodystrophy means is that the white matter is abnormal. Here on this flare image, it's very bright. This is a 7-year-old who was previously normal and developed unfortunate progressively decreased vision, behavioral changes, and seizures. And this is due to a defect in very long chain fatty acid metabolism. These genetic and metabolic disorders, like adrenal leukodystrophy, tend to present later on, and I made the point here that these tend to be normal children at birth and then develop progressive abnormalities later on. Later in life, unfortunately, we can have cases with CVI. This is a boy who was found floating in a lake. The parents pulled him out and has severe mental and visual abnormalities on examination. And on this MRI DWI images, diffusion weighted images, bright areas are areas of ischemia, and there's ischemia of the motor cortex here in the parietal regions, but for our purposes here, both occipital lobes are ischemic and temporal lobes are ischemic. So this is going to be, unfortunately, a severely affected child, both mentally and visually. I don't have cases to show you, but just in terms of infections that lead to CVI, we see cases of viral encephalitis, bacterial, meningitis, torch infections like herpes and CMV. I'm also not going to show you any cases of structural abnormalities, but these would be, for instance, cortical dysplasia, also encephalocele affecting the occipital lobes. But again, for our purposes, probably the big three, again, just to review, would be hypoxic ischemic encephalopathy, intraventricular hemorrhage, and periventricular leukomalacia. And I understand we'll have questions later, so I'll stop there.
Okay, can people hear me? Okay, Janelle, can people hear me?
Loud and clear.
Loud and clear, okay, very good. Thank you, just wanted to make sure. What does the C in CVI stand for? This is the first question I usually get from colleagues regarding CVI. Does the C equal cortical? Does the C equal cerebral? The C does equal confusing. Most of you know me by my nickname Skip, and my objective tonight is to clarify this conundrum of the C. Why is clarifying the C so important? CVI is the leading cause of pediatric visual impairment in developed countries. It is increasing in prevalence. If you see children, it is absolutely unavoidable. To promote clear communication with colleagues and to promote clear communications and explanations for parents. A few words of introduction. As ophthalmologists, we are all familiar with the sensory functions of the occipital lobe: visual acuity, contrast sensitivity, color vision, peripheral vision, and stereopsis. CVI includes the sensory functions involving the occipital lobe. However, most of CVI is concerned with the integrative side, which involves areas of the brain anterior to the occipital lobe. This incomplete list includes visually guided reach, akinetopsia or motion perception, diagnoses, topagnosia, and alexia. The CVI literature is saturated with the concept of the dorsal and ventral visual pathways or streams. The dorsal or aware pathway includes the occipital, parietal, and frontal lobes and allows us to sense and localize in space. The ventral stream or what pathway allows us to identify objects, faces, color, locations, etc. This is an MRI of a 1-year-old child that has suffered a left middle cerebral artery stroke involving the parietal, frontal, and temporal lobes. How will the child's vision be affected, and how can we assess it? Of note is that the occipital lobe cortex is primarily spared. Visual acuity is anticipated to be normal. A visual field defect is likely. It is also likely that the dorsal and ventral stream functions will be affected. How do we assess this in a preverbal child? This is the best conceptual graphic I've seen that combines the pathology and visual manifestations of CVI with societal reactions and finally the child's response. In the center is the brain pathology and how it affects visual function. In the first ring are some of the child's resulting behaviors. In the second ring are the abnormal visual manifestations that we as physicians and others observe. In the outer ring are reactions of unsympathetic and unknowing people in the child's world. Lastly, the child's psychological responses are in the outermost space. This figure is not complete in its detail, but the concept is excellent, and when you have some time, spend some time with it. We physicians and TVIs and parents define cortical and cerebral differently. Physicians think in terms of anatomy. Cortical is cortex of the brain. Cerebral refers to the cerebral hemispheres. Teachers and parents ascribe different meanings to these terms. To them, cortical refers to the work of Dr. Christine Roman and others. It involves the CVI range and CVI interventions. The term cerebral refers to the work of Drs. Dutton, Lewick, and others. It involves multiple assessments, instruction, adaptation, and habilitation. For those unfamiliar with the term habilitation, it refers to a process to improve skills not originally present. Take-home point, when you as a physician are talking to parents and teachers of the visually impaired, and you are both using the term CVI, be aware that they are not thinking anatomically. They are thinking of CVI as a system, either of the cortical or cerebral type. The two foundational texts I have used to gain understanding into the cerebral system are these, and they are in your bibliography. These are the two foundational texts I have used to gain an understanding into the cortical system of CVI. There is a growing literature in CVI, most of which is outside of the journals we as ophthalmologists read, so the textbooks will be relevant. Generally speaking, the cerebral system is prevalent in the US West Coast, US Northeast, and Europe. The cortical system is prevalent throughout the US and other areas beyond the US. CVI is defined differently by the two systems. In the cortical system, CVI is best identified and diagnosed by an eye exam that cannot explain the profound lack of visual function, a neurologic diagnosis, and the presence of a unique visual and behavioral characteristics. The characteristics are the foundation of the cortical system. At least one characteristic must be present. In the cerebral system, CVI is defined as an inclusive concept relating to children with visual disorders or visual perceptual issues of any type or severity, resulting from damage to the visual pathways and centers of the brain. Neither cortical or cerebral systems include the abnormal visual behavior of autism spectrum disorder, attention deficit hyperactivity disorder, or learning disability. However, CVI can coexist with these disorders. My apologies to Drs. Roman, Dutton, and Lewick if I'm missing something here. Each system has distinct assessment tools that share some commonalities. In the cortical system, there is the CVI range score, and it is created using interviews with parents, teachers, and other caregivers, observations of the child, and direct assessment of the child's response to visual stimuli. The cerebral side uses multiple methods, which we will detail in a moment. The characteristics of the cortical system are the following, and I'll give you a moment to just read through this list of 10. Each characteristic is scored using the scale presented here. This is based on observations, interviews, and directly working with the child. The scores for each characteristic are added together to give a range score. The assessment tools for the cerebral system are the following. They include medical history, habilitation history, and a focus questionnaire. Observations are made of the child's task performance. Visual functions that we are familiar with are measured. A functional vision assessment is made. Assessments are also made of the child's developmental and educational skills. The environment, teaching materials, and the child's motivators are also assessed. Based on the assessment tools, the child is placed into one of three groups. In the cortical system, there are phases. Phase 1, not engaging the environment. Phase 2, engaging the environment and building meaning in what is seen. And phase 3, engaging the world and adding to or enriching the meaning of what is seen. In the cerebral system, there are three groups as well. Basic functional abilities, development of complex skills and behaviors, and application in functional and meaningful activities. Interventions and processes are designed to move the child from lesser to more robust levels of visual function. These are represented by the green arrows. Both the cortical and cerebral systems design a goal-driven plan of interventions and processes which are implemented by teachers of the visually impaired, occupational therapists, and parents. In the interest of time, I will allow you to read the detail on this slide on your own. I would like to leave you with the thought that the child is the child is the child. The child's pathology and how the visual disorders present are the same whether you call it cortical or cerebral. Because of this, I think a better clinical term for this disorder is brain-based visual impairment. The definition I use is in small print. Several of my colleagues are also using this terminology, and it is now making its way into the literature. It will be less confusing and in many ways more accurate to define cortical visual impairment and cerebral visual impairment as systems of analysis and intervention. Also, there are other systems around the globe. Dr. Pare in India has published a system which blends visual functions and elements of the cortical and cerebral systems. Dr. Ravenscroft is one of the more innovative and creative thinkers in the field of brain-based vision loss. Check out cviscotland.org to learn of his ideas on theory of mind and visual representation. To summarize, cortical and cerebral visual impairment are not different neurovisual pathologies. They are distinct systems with some commonalities by which to understand and improve the visual function of the child with his or her unique form of brain-based vision loss. Both systems are widely used to address brain-based vision loss. I'd like to thank Jennifer Galvin and AAPOS for this opportunity to share my thoughts on this endlessly fascinating topic. And thanks to you all for spending time with us tonight.
Hello, I'm assuming everyone can hear me.
Yes.
Okay, perfect. So I'm Terry Schwartz. I've been asked to talk about validated screening tools to help us understand and maybe one day help diagnose CVI or brain-based visual impairment. I think my previous presenters have already talked about the challenges of CVI, and I just want to emphasize a few of them, and that is really there is a lack of consensus across the globe about the criteria for diagnosing CVI, about the approach to detecting vision impairment early, classification of different CVI subtypes, and also the need for individualized interventions for each child. So what I want to share with you is how we might look at the role of a questionnaire to help us sort some of this out. What might be the goals of a questionnaire? Well, the first could be helping us to identify early the child at risk for CVI or showing visual behaviors associated with visual impairment, assisting in diagnosing a child with CVI, helping to define. Sorry,
Sorry,
what?
we can't see your slides.
Oh no.
Mind flipping those on?
Yeah, sorry. I thought you could see them. Can you see them now?
There we go.
Okay, sorry about that. And so I just mentioned defining the impact of vision impairment on different activities in life, such as education, the ability to safely move around, to participate in social relationships, and finally, to plan individual interventions for each child. So what constitutes a good questionnaire, the ideal questionnaire? We're interested in tools that are reliable, that have demonstrated validity, and that are using valid psychometric measures. So tonight, we don't have much time, and so I just want to give examples of 3 different types of questionnaires. The first, questionnaires that are used as screeners for the presence of visual impairment. The second is a questionnaire used to identify particular behaviors that have been associated with CVI. And the third, a questionnaire that can be used to develop an individualized intervention and maybe assist us with diagnosis. So first, let's look at this screening for early screening for visual impairment. And we're going to just quickly look at 2 different types of questionnaires. The first is called the previous or the pre-verbal visual assessment. And it's a simple 30-item questionnaire. I use this all the time in my clinic. Obviously, it's not used to detect children that have severely abnormal vision, but kids in whom you suspect may be having a problem and you want to compare them with age-matched norms. So it's designed for kids from birth to 24 months, and it looks at questions related to 4 areas of visual function: attention, communication, visual motor coordination, and processing. It's a valid and reliable tool. It's 80% specific for picking up visual impairment and fairly sensitive. This is just a picture of the simple questionnaire. You can see it's a binary questionnaire, a simple yes or no answer. And it's scored as a function of age. So this is just an example of a scoring section for a child 2 to 4 months. The group is Spanish speaking, so there's a little mixed language on the questionnaire. And so this is a typical report out of my clinic, basically explaining what the questionnaire is, and for each domain, looking at whether this is an area that we are concerned about, is age appropriate, or something that we're monitoring. Another visual skills inventory was designed looking at a group of children from 7 months all the way to 16 years. And these kids had vision in the range of typical vision all the way to no light perception. 16 questions are administered, and it turned out in post hoc analysis, 11 questions were found to be the most predictive for demonstrating vision impairment. This is the 11 question pared down version. And I haven't used this, but again, it's a validated questionnaire for those kids that you're concerned may have visual dysfunction early. And again, these 2 questionnaires are not CVI specific. So let's look at 3 different questionnaires that look for visual behaviors associated with CVI. I want to really hammer on this first one because this is really a very interesting integrated website, and I think you can see the URL up at the top right. This is developed by Els Ordebus and her colleagues in the Netherlands. And not only does the website have these screening tools, which I'm going to talk about in a second, but it has a database of tools for CVI detection. It has resources for teachers, for educators, and it also has resources for teaching methodologies to help push the child with CVI towards literacy. So there are 3 screening tools. The first one is for children with motor disabilities that are non-ambulatory. The next one is for children developmentally 2 to 6 years of age, and you can see the third is for 6 to 12 years. And this is just an example of the screening list for the older children. And what you see, it's a Likert scale, actually 4, so not quite 5, but 4 choices. And the underlined questions are questions that are most highly correlated to a diagnosis of CVI. And then what we've created is a very simple, transparent overlay to help us score it in clinic. And this is a typical report that I'll include that just says that we administered the test, and it's to assess the presence of behaviors that are found with kids in CVI. And so I might write something like this: the child scored positively for this many identified screeners, and of the overall questionnaire had this many positive responses, again, associated with CVI. And according to our findings, this child is showing visual behaviors consistent with CVI, not diagnostic of, but consistent with. On the website, the thing that I find most helpful is that they've created a screening model for kids in whom one suspects CVI. And that is basically an algorithm that helps you make decisions about, first of all, based on the screening tools. And even if there's a negative screen, what do we do with that child? And I think it's helpful for me, and I see a lot of kids with CVI. I think it's helpful for people that see it less frequently, but need some guidance. The inventory of visual function, I think Skip alluded to. This is the work of Gordon Dutton and his colleagues. And basically, it's an inventory of targeted non-leading questions looking for behaviors that are typically seen in kids with CVI. And so the questions could be administered to parents or caregivers, or the child. But this is a questionnaire for kids whose vision is 2200 or better that can be measured with optotype acuity. It's segregated to dorsal stream and ventral stream visual function questions. And again, here's just a sample of some of the questions, and the parent answers according to a Likert scale. So the same group has looked at taking out 5 questions, and you'll notice that these are mostly questions associated with dorsal stream motion functions. And they've looked at these 2 questionnaires to see if they are valid and predictive in any way of CVI. And it turns out, not surprisingly, that between the 2 questionnaires, parents prefer the shorter version. The nice thing about the short version is that there's no overlap. It's primarily dorsal stream sampling, but there's no overlap with social communication questionnaires that are usually associated with autism spectrum disorder, because sometimes it's awfully difficult to tease the 2 conditions apart. I will say that the questionnaire, which has many questions, has a higher sensitivity, but in a quick clinic screening, I've often used the 5 questions just to get some idea if a child is showing some visual behaviors associated with CVI. And finally, I want to mention 2 questionnaires or 2 screening tools that are associated with developing individual interventions and may be diagnostic. The last one may be diagnostic. So the first one is, again, from the Dutton group, and it's called the Insight tool. It's web-based, and so anyone who works with kids with CVI can get permission to access this on the web. The instructions suggest that the diagnosis of CVI should have already been made. And then this is, again, a structured interview that will depending on what the particular visual behavior is, so in this instance, trips, moves over toys, and obstacles on the floor, will give a list of suggested interventions for therapists and educators or parents to try to work with that particular behavior. It's an interesting approach. The difficulty that we have found is there's a lot of duplication in recommendations, so that you can actually generate 30 pages worth of approaches. So it takes a long time to eliminate the duplications. But in an area that may have very few people trained to do intervention for CVI, it may be helpful. And finally, I want to mention this most recent questionnaire, the Flemish Cerebral Visual Impairment Questionnaire, that looks at kids 3 to 6 years of age. It's a 46-item questionnaire completed by the caregiver. And again, it's a yes/no binary response. And they did use post hoc factor analysis to look at a 5-factor model that may, in fact, show to differentiate CVI versus no CVI. But short of being diagnostic, it provides very useful information to look at the complex clinical picture that children with CVI present, and also to evaluate the functional impact that these behaviors have on daily activities, educational activities, and quality of life, and is a beautiful starting point in the setting of a multidisciplinary evaluation to individually tailor interventions for our kids with CVI. I want you to notice that all of the bibliography is going to be available on the talk, so everything that I mentioned is right here. Thanks.
Useful for planning.
Let's see, webcam, yeah. Go to meeting. Let's see, I'm having problems with the. See, I'm having problems with the screen here.
Lindy, you're having problems with your slides?
Yeah, let's see if I can try it again here.
Maybe close out and open it back up.
Okay. Yeah, I can't get out of there. Okay. Can you hear me and see it now? The first slide?
Yep.
Okay. Okay. Let's see. I'm not sure if it's gonna.
I see basic principles slide.
Okay. Just you still see basic principles slide?
Yeah.
There should be the first slide is there. Oh my goodness.
Oh, there we go. There's the first slide.
Okay.
Are you able to advance?
Can advance that.
Oh, there we go.
Okay. Okay, I think I got it. So let me try and start. Okay, it's Linda Lawrence here, and I'm an ophthalmologist. I've worked in the field of early intervention quite a bit over the last 30 to 35 years. And I really want to make a passionate plea for early identification should lead to early intervention. And my talk's mainly on supporting families and babies with brain-based visual impairment, or CVI, as we've talked about. And I want to just acknowledge all of the people, not only in this webinar, but those of us who are in the CVI field who share slides. So some slides we all share together, and I appreciate those. You know, the impact of visual impairment begins at birth. And one of our jobs is to remember that, and to remember that this infant, such as this baby who is born with congenital Zika virus, already has all those high risk for having CVI. And we shouldn't wait for an MRI scan. We shouldn't wait for diagnosed developmental delays. We already know this child is at risk, and we need to get them into referral in the appropriate systems to help with bonding of the parent, which is so important in this early stages. So we just don't want to wait all the time for a diagnosis. The basic principles in low vision that we have to remember is that we as ophthalmologists and eye care providers are often the gatekeepers to better quality of life in persons with low vision. And if we sit back and say, wait and see what happens, see if this delay gets better, we may actually be penalizing this child and family for proper interactions. We should direct towards the proper resources, provide information and guidance, and first do no harm. And that may mean that delaying referrals can mean delayed assessment and intervention, so even further delays. The goal of pediatric vision rehabilitation, or habilitation, is to maximize the function of the whole child, not just the vision, and the earlier the better. And this is to enhance educational potential, increase independence and quality of life for the future of this child. So the early detection of visual impairment identifies barriers of the child to participate in development and education. To help the child and family, we need to have appropriate services, and that is an IFSP, or individual family service plan. And as you notice in the birth to 3, this is about the family, not just the child. Later on, we talk about education of the child in the school system, but in birth to 3, we're talking about a whole family. So let's look at an example. This is a little baby, very premature birth weight, 540 grams, 23-week gestation, had ROP, had adequate treatment with anti-VEGF. He was not sent into an intervention program until he was already 1 year old, okay? He, of course, had delayed visual responses expected because of the prematurity. And we know in children with ROP, even after treatment and great anatomical performance, that 14% of them still have low vision. So this is a child who, at the time of diagnosis of ROP, should have been sent into an early intervention program. So we have vision screening, vision, you know, this child's at risk by the physician, nurse, or trained staff that should then get the medical diagnosis and appropriate ophthalmic treatment by the ophthalmologist. Then our next important step is referral to educational services. And this is a step many of us don't know how to do. And it's different in state to state, community to community, country to country. Those educational services then call upon the appropriate other therapists. If you're in a big academic setting, you may be used to, oh, I have this low vision service next door. Oh, I have this blind school on the next street. But most of the ophthalmologists out in solo practice, private practice, outside of university settings, don't know where that referral might be. So I'm going to talk a little more about that. So how early is early to do an assessment for low vision? If you read the work of Daniela Ricci, a neurologist from Italy, it's quite fascinating. And she has validated testing that shows that fixing and tracking is already present at 30 to 32 weeks of gestational age. And she's devised, along with other researchers in Italy, a whole system of how to assess visual impairment even this early. So waiting till they're 1 or 2 or 3 is way too late. And early interventions should start at the time of diagnosis of the visual delay or disability. Now, delay implies that this child is going to return to normal, or this delay in whatever development is going to return to normal. Disability is something that starts as a delay but will affect the rest of the life. Okay, so there's some confusion sometimes on what is delayed visual maturation and what is actually CVI in the early stages. And we must find appropriate services and supportive structures for the child and the parents in this community. In early intervention, it has to be family-centered and a team approach. This means medical, family, and education. Okay, we as medical doctors cannot specifically prescribe educational interventions. We can suggest it, but it is not in our realm of practice. We can work with a team and guide a team, but in the end, it's the therapists who apply that to the coaching of the family. Okay, and we want to use the residual vision to help in perceiving the environment and overall development in the child. So again, early intervention is where the family of the infant and toddler gets strategies to help the child access and explore the environment to learn what those typically developing learn incidentally. This includes social, motor, and use of residual vision with other sensory modalities. And it takes a team. It's not just one therapist or one person. The early intervention team in the US for birth to 3 is under Part C of the IDEA Act. This includes the parent carers, child, other medical, education, therapeutic professionals. This examination, there's free assessment and interventional recommendations for a child birth to 3 in the United States in every community. It varies state to state whether all of the interventions are free, but the assessment is free and is to be done within a month of referral. Now, the referrals to Part C program can be a professional, a community person, a parent who's concerned. You as the ophthalmologist can directly refer for an evaluation to an early intervention program. Most of us think of referring to a teacher of the visually impaired or low vision center, but that child who has low vision as a concern in any way should go into an early intervention program where a special childhood early developmental specialist, teacher, along with the other therapists can do a proper overall assessment of that child. These babies, vision affects everything. We can't concentrate only on the vision. The coaching model that we have here in the US uses early interventionists to coach the parent to enable them to support the child and family. The parents are taught to teach the child to do the interventions because the parent has the child 80% of their waking hours. Other professionals may have it 5 to 10%, even in school-age children. Services in the US are usually provided in the home environment, and although this may not be feasible in other countries, the point is to make it accessible to the family. And the interventions need to be part of the parents and families' daily routine, not just therapy that's done once or twice a day. Now, for the ophthalmologist to assess functional vision, we have all of these tools. Some of them have already been talked about, but what we need to understand is visual developmental milestones. These are now published milestones, the references there, and we should learn these. They're easy, we can check them very easily, and then we can know if that child has overall developmental issues that need further addressing. This is a poster that they use in India so that the parent can look at the child and say, you know, my child's not doing what they should be. I need to go see my pediatrician or teacher or developmental specialist. And as we do our interventions, we can also make suggestions, realizing that these specialists are going to further refine those. For example, if we have a child with a lower visual field defect, we can tell the parents, you know, start with feeding or looking at the child from above. In this case, with the something like the layup puzzle, when I do this with the children, if the child has difficulty with orientation, I can instruct the parents to, you know, start with the child laying things in an order, and then the therapists really do the fine tuning on this. I think one of the things we as ophthalmologists think we need to know all this, we need to be part of a team. What we should be able to do is do a proper refraction, think about it, use dynamic retinoscopy, and understand that these children do not fit into our typical category of when to prescribe glasses. Children with any low vision, developmental delay, or CVI may need glasses for a different reason than is typically thought of. There are published papers on this and how to correct refractive errors and hypoaccommodation with over plus glasses. And this is a little booklet that was published from the New Mexico School for the Blind that goes through, you can download this, and it goes through indications for glasses in the birth to 3 group so that parents can better understand why their child may need glasses. Telehealth has added a whole new dimension to doing intervention in the birth to 3. We do a lot of televisits. There's pros and cons. We've been able to actually do a lot of things that help support the low vision team and the parents in this time where we can't have face-to-face interactions, such as in this little girl has a head turn. We could explain the reason for the head turn and what might be appropriate interventions. And on the lower right is a boy with CVI, and we're actually testing his visual fields at home via Zoom. So I encourage you to remember, these children are developing now. They can't wait till COVID is over. We need to devise ways to interact with our early intervention colleagues, our teachers and therapists to help support these children during this time. Thank you.
I want to thank the organizers for inviting me to speak tonight. And I have, I think, more questions than answers in this topic. And basically, I want to call the attention to older children and young adults with CVI. And I have grown up in CVI or brain-based visual impairment with my patients and families, and they've taught me a lot. No disclosures. I'm going to skip over a few slides because folks have already talked about diagnosing CVI and definitions, and go right to special needs of older children with CVI or brain-based visual impairment. Children may go undiagnosed because of their multiple disabilities. There are many studies that show that children with multiple disabilities may have visual impairment that's not being diagnosed. Pilling in 2017 showed at least 33% of children. This is has been documented in other studies. There was recently a study that showed 92% of children with multiple disabilities had visual impairment, but they did not, they also included refractive errors or correctable causes of visual impairment. And what are the other special needs of older children with brain-based visual impairment? The children that are higher functioning is one population that has special needs that are not always met. And that includes age-appropriate educational, vocational, and activities of daily living. Older children need developmentally appropriate visual materials. And why is this gap important? Well, it's important because, as you saw tonight, most of the assessment intervention strategies are for infants and young children. And that's a problem because older children and adults are not small children. And it's important to remember, as other people have discussed, that every child and older child and young adult is an individual child who is going to grow and change and need reassessments and changes in what interventions are done. So there's this lack of attention to the special needs of older children. Some of them are just not going to get to where they need to be. It's going to limit them. And we need to consider that needs don't go away just because you graduate from high school or that you're entering a workforce. There was a study in 2019 that did a gap analysis and showed that there is great opportunity. There are many unmet needs in the lifespan of adult individuals with neurodevelopmental disorders. And I see this frequently in my practice. How do we make it better? Well, again, I look to all of my colleagues to help me with this, but I may have a few ideas about this. We need to create a way that the competing and overwhelming medical issues, the profound complexity of these children, we need to make vision more of a priority. Right now, it's a lesser priority, and we need to make sure that it's a higher priority. We should not make assumptions about children or young adults based on what we may think they can do. I have learned from many families that we should not make assumptions. Older children may have some different needs, if they're doing geometry or they're doing literature. And I have a quote from one of my patients about that. And another is that I often see older children who are watching cartoons that are really not age appropriate. I was taught by a family, their child, I said, well, I always ask about hobbies and what the child likes to make sure that they're getting that part of their recreation. And the father said, well, he really seems to like about astronomy, but of course, we don't, he can't understand that. And I said, well, why don't you try, the child needed an auditory presentation of material. And the father, when they came back, told me, he listens to these lectures about astronomy. And I felt bad because they had not been fulfilling this need for that child. I like to take the advice of one of my patients, and he is a college student now, and he talks here about the fact that he does math with complex symbols such as integrals, whatever that is. I really don't know, but I will go down a little further here, and it says that he has trouble, keeping track of these symbols, and he's developed his own strategies, and based on his accommodations when he was younger, although he was not diagnosed until about 10 years of age. But he puts additional spaces between different problems and each line of his solutions so that he doesn't get confused between the different lines. He also writes numbers and mathematical symbols in red to make it easier for him to recognize them in word problems. And again, for many, as life gets on, the work gets more complex, and complexity is often one of the biggest problems for children with CVI. Again, I brought up a lot of questions. I wish I had more answers, but I want to make everybody sensitive to the fact that we need to do not only a better job for infants and young children, but our older patients who are going to go to college and who want to drive a car and be sensitive to their needs. And thanks to all my patients and families who teach me every single visit. Thank you.
Hello, everybody. Just a few more minutes until you can go watch the presidential debate. I'd like to highlight for you what families need from eye care providers like you. I come from a unique perspective as a pediatric nurse practitioner and a parent of a child with CVI. the leading cause of visual impairment in children, and I strongly believe that our children can learn to see. I'm going to share with you Krish's story. My son, I call him the luckiest kid. My son is a lucky one, born at 26 weeks and 4 days, 1 pound, 6 ounce, twin B, C-section from complications related to preeclampsia and IUGR. His medical history includes grade 2 IVH, prolonged intubation that resulted in chronic lung disease, ROP that did not require treatment, GERD, failure to thrive, and a 4-month NICU stay. Once home, he started PT immediately through early intervention because we knew that he was at risk for significant delays, and that's when we noticed he wasn't looking at us. He had a twin to compare him to. The PT listened to my concerns, referred him for an early intervention vision consult. The teacher of the visually impaired, or TVI for short, had been seeing more kids like Krish recently. She knew he likely had CVI based on his visual behaviors and birth history, but she couldn't diagnose as a non-medical professional. We started with weekly sessions to stimulate his vision. We had been to the ophthalmologist weekly for ROP follow-up, and to be honest, Krish slept through most of his exams. After I started to bring up his abnormal vision, he received the diagnosis of delayed visual maturation. Completely understandable and appropriate for his age, but there was no talk about what else it might be. Based off the concerns of the TVI and his abnormal vision, I was able to get a letter from the doctor to support vision services from early intervention. Our ophthalmologist admitted she wasn't too familiar with CVI, but was happy to support Krish in getting services. So we set out to find someone who could give Krish the diagnosis with confidence. This proved to be very difficult. We followed with the developmental pediatrician, but she didn't believe he could have CVI because all the kids she had ever seen with CVI were multiply impaired and appeared blind. We saw a neuro-ophthalmologist, and he agreed maybe it was CVI, but maybe not. There was a special needs optometrist who said he couldn't have CVI because he looked in her direction when she flashed the teller acuity card. She didn't understand that the movement of the card was enough to draw his attention towards the card, but not necessarily see the card. It wasn't until we saw Dr. Roman Lancy out of her pediatric view clinic that our diagnosis was confirmed. This clinic evaluates the child from a developmental, visual, and educational perspective with simultaneous developmental piece assessment. Families go there after any other coexisting ocular impairments have been ruled out as the cause of the vision issue. Dr. Roman uses the CVI range, a validated visual-educational assessment, to evaluate functional vision. You may be thinking, this is an educational tool that you would not use in your practice. However, you serve as the gatekeeper to access this tool from the TVI. These are the characteristics of CVI, which Skip has already shown. So I'll skip over this. But the things assessed in this visit with Dr. Roman is the level of detail that we would like to get from eye doctors. In the past few years, Krish has been diagnosed with mild CP and PVL and other accompanying brain damage. We have found our local CVI expert, Dr. Lehman, who is a tremendous resource. The results of his vision exam show lower field deficits, strabismus, amblyopia, latency, processing and expressive delay, and difficulty with faces and complexity. I want to highlight the overwhelming position parents of high-risk children are in with the multiple specialists and appointments we have. It takes a lot of work to get this diagnosis. Currently, Krish is in phase 3 CVI according to the CVI range and is in a typical second grade classroom. He gets services from a TVI equivalent to that of a blind child. All his materials are adapted, primarily on an iPad, although some of his learning is auditory. Other adaptations include decreasing complexity in his environment, decreasing competing stimuli, and highlighting salient features of pictures using realistic images and objects. He gets orientation and mobility, PT, and OT. He has learned to read fluently, but struggles with writing, so he prefers talk-to-text, predictive text, or typing. He struggles with fatigue, visually and physically, and will stop using his vision, appearing blind. He uses a white cane in a new environment. He is smart as a whip and compensates by memorizing. Kids with CVI can look typical. Kids with CVI are surpassing expectations. He was lucky in getting a knowledgeable TVI, an open-minded ophthalmologist, and access to the CVI range. All these steps happened in order for Krish to learn to see. So, current issues in CVI, points of contention between parents and ophthalmologists. Believe the parents. The visual impairment can range from appearing subtle to appearing blind, and it can coexist with other visual diagnoses. CVI is confusing because it looks different in every child, and every child looks different. Physical disabilities like CP often take precedence in the child's evaluation. Assume that all children with CVI have the ability to develop their vision. In an informal parent survey asking what advice they were given when their child was diagnosed with CVI, some were referred to appropriate services, but many were told, treat your child like a blind child, teach them Braille. It's not the eyes, it's the brain. Come back in a few months. Wait and see. Nothing you can do won't get better. This is unacceptable. Does CVI fall under a diagnosis for ophthalmologists to manage since it originates in the brain, not the eyes? I've heard this comment from ophthalmologists. There is no specific medical or surgical intervention to solve CVI, which can make providers uncomfortable. The solution to improving their vision is not easily definable. Some providers are resistant to the diagnosis, either because they don't understand it, don't believe in it, or don't know how to diagnose it. We need to improve this. Current issues in CVI impediments to success. It is a low incidence disability, so it's difficult to quantify the number of children affected. However, appropriate diagnosis and quantification of disease prevalence will improve research and resources. Misdiagnosis, prolonged diagnosis of DBM, or incorrect diagnosis with ASD because of poor eye contact and difficulties with socialization as a result of visual complexity, or a misdiagnosis with ADHD because of inattention or need to move around a space. Currently, there is very little consensus on diagnosis criteria and interventions. The debate on who diagnoses, who provides educational services, what level of services, cerebral versus cortical visual impairment, debates between schools of the blind within vision academia are all happening now, so it's easy to see why things have moved slowly in the world of CVI. Once a diagnosis is confirmed or suspected, referral to early intervention or local school for the blind. Tell the parents that vision can improve and set an expectation that the child's vision will improve if they do targeted interventions under the tutelage of a qualified TVI. Time is of the essence. Since birth to 5 is the greatest period to maximize neuroplasticity, it's important that we make this diagnosis timely. If we treat the vision with specific and targeted CVI interventions by an experienced TVI and we motivate the child visually, then all other aspects of development will improve. By treating the vision as a primary disability, we can see improvement in all arenas of development. And also a letter to obtain TVI services, orientation and mobility, and educational support. In addition to reporting acuity, report visual field deficits, preferred field of vision. And here's examples of adaptations. This is Krish's after visit summary, and this is one of a few pages that Dr. Lehman gives us, and you can see it says use of digital material is helpful. Krish requires direct ongoing evaluation and follow-up of a TVI experience with CVI, work on fine motor and OT, etc. So this actually came from our ophthalmologist. Future hope. Call for increased research and awareness and education of new clinicians. Utilize a screening protocol for at-risk children to identify high-risk medical historical events and visual behaviors that increase the suspicion for CVI. Expand categorization of visual impairment to include CVI or brain-based visual impairment. Make CVI an official diagnosis in the next ICD. Modify the criteria to diagnose someone as legally blind in order to access federal services for the blind and visually impaired. We need every specialist to be on board, medical, educational, and therapeutic. There can be no silos. All developmental domains are dependent on vision. Consider creating your own CVI clinic. Make the vision resources and medical management consistent across the country. Our also asks us at every appointment, what do you need from me to help Krish get the services he needs? This is actually the question that parents need to hear from you. There's an urgency to this situation. It has been referred to as a public health crisis by leading medical professionals and clinician scientists. Recently, the National Eye Institute at NIH has included CVI as part of their future strategic plan. Dr. Craig Hoyt stated, CVI is an epidemic and should be treated as such. I've asked my fellow CVI moms what message they would like me to share with you. You've seen their picture of their children throughout this presentation. Do not take hope away from families. Kids with CVI can improve their vision. Stop saying wait and see. Refer to educational resources with a TVI as soon as CVI is suspected or child presents with high-risk factors. Write a detailed letter in support of vision services, including a TVI and L&M specialist. Include your assessment of their functional vision. Children with CVI have a right to an early diagnosis. No child is untreatable. Every child can learn to see. Visit pcvis.vision for more information for you and your patients. Thank you.
Thank you so much on behalf of everyone. It's an excellent talk. We're going to repeat some of the questions here. Eric and myself, on behalf of the Online Media Committee, there have been some questions. This first question, I believe, is to Dr. Legg, but anyone can answer it. If a child has normal, typical development, but then develops visual issues at the age of 7, is this still considered CVI?
I'm muted too. Oh, okay, there. We're back. So the child that presents at age 7 with abnormal visual function, I always go back to the criteria for brain-based vision loss. And, first of all, can you explain their vision loss based on any kind of ocular disease that they have? And if you can't, and they have a neurologic diagnosis of some type, then I think you can get to the diagnosis of brain-based vision loss. Otherwise, it's very difficult.
Thank you.
Yeah, another aspect of that too is it can be acquired. We talk so much here about congenital forms of CVI, but there certainly can be acquired forms too. So it's certainly possible that a 7-year-old can have a newly acquired form of brain-based vision impairment.
Thank you. I believe this question is for Dr. Liu. How does the ophthalmologist distinguish between the ocular cause of vision impairment and CVI? Because there are syndromes in which there are both optic nerve and cortical cerebral abnormalities which impact visual performance.
Yes, interesting question. And Skip, Mark Borchard, and Christine Roman and I have discussed this very topic. And sometimes it is very, very difficult. But let's just talk about the obvious causes of ocular problems that would cause vision loss in this setting. So if somebody had obvious optic atrophy, optic nerve hypoplasia, retinal pigmentary abnormalities, then you don't know how much ocular vision loss there is, and then you probably wouldn't be able to make a formal diagnosis of CVI. I think if you had just a little bit of optic atrophy, I think you're, and the brain disease was severe, I think you're okay making a diagnosis of CVI. The bottom line is you have to make your judgment, and it can be very, very difficult. But if you can decide that the majority of the vision loss is brain-based and not so much ocular, I think you can make the diagnosis.
Okay, thank you. That's excellent. The next question didn't specify as to which panelist, but the question is, would you recommend strabismus surgery for exotropia frequently seen in children with CVI? Any of the strabismus surgeons?
Yes.
So I'm going to give 2 scenarios. One, if a child has CVI but also has a hemianopic defect, sometimes kids will develop exotropia in response to field limitation. And so I think in that sense, it's a little controversial because you do limit the functional field. On the other hand, a lot of our kids with CVI are nonverbal and require, for example, eye gaze technology for communication. And in those kids, sometimes having an exotropia or even an esotropia can interfere with being able to use augmentative communication.
Okay, oh, that's excellent. Thank you. This is also, this wasn't specified who this question is to, but do you need abnormal neuroimaging for a diagnosis of CVI?
No.
No.
I agree.
But almost. always, but no.
This question is for Dr. Lawrence. What does early intervention look like for a 6-month-old child? That's the question.
Okay, yeah, early interventions, I work directly with our program, and when we have a child with suspected CVI, say from an extremely premature infant or some kind of brain abnormality, they have an assessment by a whole team, OT, PT, each, and then a vision teacher is brought into the team depending on what's found. But the team has complete assessments for age groups starting with newborn. We actually now in several centers in the US have teachers of the visually impaired who actually go into the NICU and start at the time where a child is at very high risk for CVI to help train the parents how to do bonding in a child who may not have the ability to look visually at the parent. So, you know, it starts at the earliest diagnosis. The interventions should start, and you get a team on board and who's trained in the proper ways to help with overall development.
Okay, oh, that's great. Thank you, Dr. Lawrence. Dr. Lawrence, this question may also be for you. It says, do you use or suggest using NAVEG, which is the Neonatal Assessment Visual European Grid from Dr. Andrea Rossi and colleagues to detect patients at risk in the NICUs?
Yeah, and I think, and Terry might be able to answer some of that too, but I think this is actually being looked at now in a couple centers in NAVEG to see how that can help us with early identification. The cases, the strategies I present from Italy are now part of an 11-center trial there that I think, you know, a lot's come to stop with the COVID, but there are those two types of assessments being looked at for the earliest identification actually in the NICU. So we can get those kids into services and start really looking at how to really get the habilitation started. The earlier the better. That's a really good question. NAVEG's not that widely used in the US, but I think we're all becoming more aware of it.
Linda, I would say we don't, oh, sorry.
No,
Sharon?
go ahead.
No, go ahead.
I was just going to say that we're not using it. We were supposed to start a trial of another approach to early diagnosis in the NICU that came to a screeching halt with COVID. So, but I think it's a great tool. So.
Oh, Dr. Lehman, did you want to say something also in response?
No, I agree. And one of the things I would just say is I don't want ophthalmologists who are listening to this to get overwhelmed. You know, we are all CVI people who love CVI, and you may not have to do all of these questionnaires. We want you to use some questionnaires, but just remember, don't get overwhelmed with all this. And there are easy ways, especially with the electronic medical record, to do some of this work. So we can help you get better at this, and there's quick ways to do it. And we'll continue to try and continue that education for all medical providers.
Okay, oh, thank you. This is a question for Gunjan. What is the single most important thing you did to help translate information from the medical model to the educational setting to obtain services for your son?
How did I transition medical? I mean, kind of what Linda was talking about, you start with early intervention immediately. And if you have good early intervention providers, some of them came with us to our medical appointments. And it starts to, once you get your diagnosis and once you understand, I mean, obviously you continue going to the ophthalmologist, and you take their guidance. But really, for us, the teacher of the visually impaired took over, because having putting all the interventions into the PT and OT, having vision as the basis, guide all the other interventions, is what helped us become successful in the educational arena.
Okay, that's great. Thank you. Another question that I believe is for Dr. Lawrence is, at what age is O&M training typically given in a child with CVI?
That's really an educational question I leave up to the early intervention team. We're really lucky in our community that a lot of our teachers of the visually impaired TVIs are also trained in orientation mobility. And so once we access the TVIs, they may also be O&M. So we start very early, because orientation mobility is actually learning how to get through space and time safely and independently. Mm-hmm. And this starts as a baby. I think the other thing that happens is it's assumed, oh, they're getting physical therapy. Physical therapy and orientation mobility are two different things. Mm-hmm. They're two professionals who hopefully will work together depending on the needs of the child. The child also has motor impairment, but orientation mobility can start, and we started early and earlier. It used to be, oh, when the child's walking, we'll start O&M. Now we start it right away. We get O&M involved. So we've got to get the O&M providers. I think a lot of them are more and more interested of working in the very, very earliest time of these child's life. And a lot of it is them doing a consultation with the team and then determining when's the next best time to reassess the child. We don't have to say, oh, come once a year. That's not our role. Our role is to get them in the services. They do the assessment, the consultation, and do the appropriate interventions according to what needs to be done.
Can I add one thing to that, Linda? And that is, it's up to us as physicians. We can request an orientation and mobility assessment anytime. We can't prescribe orientation and mobility, but we can ask for a formal assessment, which then the school will provide and determine if it's appropriate. So,
right.
It's so helpful to have the ophthalmologist backing you, even though it's some of the approaches are therapeutic and not medical that the educational team is doing. Having the ophthalmologist report makes all the difference in the IEP or IFSP in early intervention.
Yeah, and I agree with that. In Nebraska, it's very, very difficult to get these assessments and intervention unless a medical provider writes a letter that recommends interventions or assessments from the teacher of the visually impaired. So I would just urge my colleagues out there to try to become comfortable in writing those letters. And if you need us to help you with that, we're happy to do that.
Thank you. This is also a question for the panelists. The person says, I am referencing an article that's NEI supported research lays the foundation for rehab brain-based visual impairment. This was published in July of 2020 by Dr. Marabet, who's attempting to quantify with brain imaging studies CVI-related changes to the brain and functional visual deficits. Diffusion-based brain imaging reveals dorsal and ventral processing streams remain intact in people with ocular impairment, but are markedly reduced in individuals with CVI. The question is, after the reference, how might we be able to benefit from this technology to gauge which rehabilitative strategies might eventually work best? I can repeat the reference or repeat the question. It was asked 3 times, so
well, I think that this is very important work, and we need to do everything we can to be able to access services for patients. And this may be one more check mark when this work becomes more developed, to be able to say, this child has CVI, and requires, there's a medical necessity for an assessment for vision services. So I look at it as, you know, one more way we're going to be able to document and help that child be more independent and reach their potential. So I think it's a really important work.
So I'd say there's a lot of really interesting work coming out of Dr. Maribet's lab, and just in the correlation between structure and function. I'd say that a lot of this technology is not readily available to assess most kids with CVI at this point. But I agree with Sharon. I think it's really interesting for the future, but it's not at the point where it's really used to we haven't really used it to look at different subtypes of CVI, and we haven't used it really to model interventions at this point.
Oh, excellent. Thank you for answering that. That's excellent. Another question for the panel is, as a key issue is consensus on CVI amongst medical professionals, has there been a push to increase education, awareness, and training for MDs?
Absolutely. I think that the people on this webinar have been, you know, actively doing that for years, and we continue to do that. That's why we're all here tonight, is to improve education about CVI, and you know, we need people to be asking for courses on CVI to AAPOS and to the AAO and to many other of the healthcare professionals that we work with on our multidisciplinary teams.
Yes, and there are now lectures that are starting to pop up in ophthalmology residencies that do address CVI, which is a new thing. You know,
I gave a talk on it the other day, Skip. To the residents.
I mean, it's happening. It's happening, and I think the next generation of ophthalmologists will be much more educated on this. Yeah.
Excellent, thank you. Here's another question here for the panel. Is there a higher rate of CVI in premature infants? No, there is a higher rate of CVI in premature infants, but extreme prematurity in itself is not a cause of CVI. So the question is about perhaps the definition of IVH, PVL, and asphyxia.
I mean, I think there is a higher incidence. Those are the kids that are more prone to have periventricular leukomalacia, intraventricular hemorrhage. I don't know if I'm necessarily answering the question in the way the person who asked it wanted it answered, but it would be my impression that yes, there is a higher incidence.
Okay, oh, thank you, Dr. Luke. This is also for the panel. If you have no vision therapy services available at the moment, any things the parents can do at home, for instance, use high contrast toys, bright lights and sounds?
I guess I can answer that. One of the things we don't usually call the work we do vision therapy, because it gets confused with vision therapy that optometrists do, which is a different thing. So a lot of us prefer the term vision rehabilitation or rehabilitation of the whole child, because we're not just, especially in a baby, we're not just stimulating the vision. We have to teach the child to use the vision for overall development. So we're trying to use vision for function. If a child's in the early phases of CVI, then we're going to have to get the brain to learn how to use and understand that it has vision. And then we work towards using vision for function and ultimately vision for literacy. So there's a whole pathway. But if you start out remembering, you have to keep it simple, high contrast, slow, decrease the clutter, decrease the noise in the environment so the child can concentrate on one thing and learn that thing before you move into more and more complexity. That's real basic, but that's kind of how we all think of it. And even in the higher levels of CVI, it's the same thing. Looking at what is it that child's struggling with it? Is it the complexity? Is there too much stuff going on and they can't separate or see more than one thing? Is the contrast too low? Are they not given enough time? These can also translate from a small child up to an older child. But each child needs a very specific assessment and a specific program. But those are kind of some basic thoughts about CVI.
I just want to echo what Skip said, and that is that the CVI Scotland website is a great resource. I think PCVIS also has resources. There's a whole list of resources for parents online. And then the website that I mentioned, the Teach CVI website, also has a wealth of tools for parents. And the only other thing I'd say is because of COVID, we're doing a lot of our intervention virtually, which is great because we get to see kids actually functioning in their home environment, which is very different from assessing them in clinic, which is sometimes a very artificial evaluation of function. So in some ways, virtual intervention for this has been really exciting for us.
I mean, as a parent and an advocate, I often, when parents say, how do I get this help? I mean, if this is obviously a long-term, lifelong disability. So I'm like, you have to think about moving. You have to go to, unfortunately, the resources are not spread evenly across the country. There is a shortage of TBIs and O&Ms. So OTs and other specialties can come in and teach if they understand the concept of it. And there's a consult model going on. So there's people doing telehealth consults all over the country. So there are alternative ways, but it's honestly really important for the child to get into a school district early intervention program where they're going to be supported. That's the unfortunate truth right now.
No, those are excellent points. This is a question for Dr. Schwartz. What is the role of the occupational or physical therapist in the habilitation of individuals with CVI, and should they be part of the care team more often?
I love that question. So I think Linda will agree with this as well. Absolutely. So we have a strong presence with it on our team with occupational therapists. I'm at Cincinnati Children's Hospital, and if I have a child who I've diagnosed with CVI, I can ask for a CVI range. I can put an order in for a CVI range for one of our occupational therapists to perform, evaluate, and make recommendations. Our occupational therapists are doing the lion's share of virtual visits. And what this is for preschool age kids. And what I really like about their approach, it's something I've learned, is that they're using, although we measure functional vision, we're looking with them at setting goals for using kids' vision to perform activities of daily living, for example. And so there's a great assessment called the Canadian Occupational Performance Measure that lets us really set 5 goals and look at parent satisfaction with achieving the goals so that we can see that we've made genuine progress. So I think they should be included. I don't think they're always included for school age kids, but I would strongly advocate for that.
Yeah, I just like to say something along the lines of occupational therapy as well. And that is, there are a lot of states where there will be teachers of the visually impaired that aren't very familiar with brain-based vision loss and the interventions. And all of that educational intervention, at least in our state, has to go through the school districts. And some parents find themselves kind of locked into a school district where they have a TVI that doesn't have the ability to offer anything. And we took the steps of having our occupational therapists in our children's hospital become familiar with CVI, become certified in various ways to do assessments and interventions. And so you as a medical provider can intervene for your patient and write that occupational therapy consult, for CVI assessments and interventions. And there are occupational therapists that will do that. And it allows you to get services to a child that otherwise might not have access to those services through the educational system. And the occupational therapists, I think, can be very good at educating the parents and assessing and creating interventions and sharing those with the parents. And so there is a way to get services to children when it looks like the educational system may be faltering. And it's usually through the occupational therapists, I think.
And I think it's helpful as providers. It's helpful as providers to know what resources are available around you, like how it works, whether it's referral to EI or school district or school for the blind, because it's so haphazard across the country what the resources are. So it's really helpful to know whether it's an OT or a vision teacher or who you're going to be referring to help them, because that's what parents are doing right now is sending patients to specific ophthalmologists across the country or to specific areas to get the services they need.
I often ask the parents, what state do you, remind me which state you live in, because that matters.
Even state to state, and we're in a rural area. We actually in Kansas have a pretty well integrated system through our state school for the blind, but it's still a struggle. But I totally agree with you. Every ophthalmologist needs to know what the resources are in the area where their parents are coming from and try and figure out how to get them into the right resources. And it is like you said, it's not a consistent system across the US or even state to state or even in the same city. So it is still a struggle, and there's so many resources. It's good for each one of us to have a list of that we can give to the parents as a starting point and advocate with them and for them.
And Linda, I think that's a really important point, and I would ask people, I know it's hard enough to get any child help with CVI, but we need to remember healthcare inequities. And what sparked me to think about this, Linda, was what you just said about that it may be even in the same city that a child may have different issues. And I think that as a CVI community, we need to look at healthcare inequities.
I'm so sorry to cut this fantastic discussion short. On behalf of AAPOS, Dr. Jennifer Galvin and Dr. Eric Pennick, also we're on the online media committee. I want to thank the expert panelists, and just we could probably go on for hours. And I apologize to all of the people whose questions we didn't get to, but now you know there is an active forum, and we have all learned so much today with our new terminology and how we need to take care of our patients better as a way to think about this disease. On behalf of AAPOS, I'd like to thank Dr. Grant Liu, Dr. Rich Legg, Dr. Terry Schwartz, Dr. Linda Lawrence, Dr. Sharon Lehman, and Ms. Gunjan Rustigoni Wilson. Thank all of you for sharing your expertise and your perspective and making us better during this compact and very outstanding webinar. Thank you all.
Thank you.
Thanks.
Good night.
Thank you.
Stay safe, everybody.
Good night.
Good night.